very much for the opportunity to come and talk to you this afternoon. And what I thought I'd do is to just do a quick intro about the environment in which NICE operates. That's the science, politics and money bit of it. A few words about the rules-based approach that we take to this and dive into some of the details of how we are going about the business of evaluating innovative technologies and forms of practice that are increasingly being presented to us as great opportunities for improving outcomes, and then loop back out to a few words about where that's got us to and what the future might hold for NICE. So just to start off, what the first slide is going to talk about is the environment in which NICE is operating, which will be no surprise to any of you, really, because we all work in that complex world in which money is hugely important, but it complicates everything, in which our ambitions for everything that we can do, and indeed the government's ambitions for the NHS, always exceeds our capacity to deliver. The public is sympathetic to the complexities that the NHS is facing, but they just don't know how to solve the problem. And the political system struggles to confront and deal with this, which is not a criticism of politicians. If you've got stewardship responsibilities for a national healthcare system and the responsibility to fund it, you're inevitably going to face enormous challenges in securing the confidence of the public and in convincing them that you're doing the best that you can for them within the resources that are available. Though in that kind of situation, it's enormously important, I think, to be as honest as possible about what is possible and about the limitations of the offer that a publicly funded healthcare system can make. Of course, NICE is part of one of the things that we do is to help those who've got stewardship responsibility for the system at a national and a local level explain some of that, starting from the evidence, talking about the balance that needs to exist between what we can do in practice and the resources that we have available, explaining the importance, making judgments about both effectiveness of treatment approaches and also their value for money. Money isn't limitless, we can't ignore the reality of all of that. So you operate in that environment, but we do too at a national level, and that national level of operation brings particular challenges. Partly because you're operating as NICE does. If you have a national brief in the full glare of both political examination, I get at least a couple of letters from MPs every day about some aspect of what NICE does. And also in the full glare of media scrutiny. And both of those, though challenging, are enormously important, I think, in ensuring that both specifically what NICE does, we do as well as we can. And collectively, the organisations that operate at a national level are too doing the best that they can. That sunlight on the approach that we take is very important to ensure the robustness and the quality of the work that we do. And I think when you are operating in a complex environment like that, it's really important to be absolutely clear about the approach that you take, about the way you go about the things that you do. And at NICE we've always tried to do that, to be clear right from the start. We've become more sophisticated in the details of the methods and processes that we use. But the things on this slide and on the next slide coming up are things that we have always held to be very important, and we have done our best to make sure that we keep to. So selecting topics that are important to you, to decision makers in the system, making sure that we go as far as is appropriate to bring together an evidence base that's as comprehensive as it can be for the people we ask to make our decisions in our advisory committees. And critically important, I think, are the methods and processes that we use. It's essential to enable those who engage in detail with us, whether it's a company or whether it's a professional association or a patient group, knows exactly what's going on inside the NICE process and knows how they can engage with it. And critically also, the opportunities that they've got for challenging what it is that we do. And we need to be able to do that time after time in the hundreds of topics that we look at every year. So having those methods and processes is really important. And the whole business of engagement is essential. Without extensive engagement, we could be as good as we can be, as anybody might be in a closed room looking at the evidence with clever people, but without exposing ourselves to the views, the perspectives, the opinions and the knowledge of those who are going to have ultimately to put the guidance in effect, or whose businesses or whose health is going to be affected by our recommendations, is really very important. And keeping things up to date is critical too. That becomes a harder challenge for us every year as our back catalogue expands and as the volume of research relating to the topics that we've already published guidance on also expands, and we've had to become ever more clever and efficient at the business of doing that over the years. And I'll come back to that right at the end of the presentation as we look at the potential for new technologies to help us to maintain the currency of our guidance. And specifically when we are developing guidance, these things are enormously important. The independence of our advisory bodies is absolutely critical. You might not agree with the conclusions or the recommendations or all of them in any individual piece of nice guidance, but you can be certain that it represents the unfettered conclusion of the group of people that we've brought together. Professionals, patient representatives, members of the public, people with particular evaluative skills in statistics or health economics or epidemiology, the people who come together to form our advisory committees do so not because they're being paid, but because they want to do it. They're not going to be pushed around by anybody. Nobody at NICE, politicians, the media, companies, drug companies, whoever you might think. They're simply not in a position to influence our independent advisory bodies. If we tried to do that, to tell an advisory body what to do something they didn't want to do, to write something they didn't think was appropriate and driven by the evidence, they would walk away. And that would probably be the end of NICE as an organisation, since our credibility, I think, would have been fundamentally damaged. And then these other things too are always there, present in different ways, given the different topics that we look at and the different nature of the evidence base that we have, that stretches right across from the sort of topics that you were just listening to in the treatment of cardiovascular disease, across to the work that we do for social care to support those who are running small homes and big businesses in social care, to make sure that the options that are available to those that they have responsibility for are driven as much as possible by the evidence that's available. And the other things too about the opportunity to comment, as I've said, is critically important. And when we finish any individual piece of work, the advisory committee are asked to identify what they regard as the key research questions. What is it that they would have liked to have known that would have helped them to formulate guidance more quickly or more confidently, or to be more comprehensive in the recommendations that they make, that they simply didn't have available to them. And we ask them to formulate those into questions which we can then take to the MRC or NIHR through the connections that we have with the organisations that fund research. Not with any requirement that those research bodies will undertake that research, but with considerable confidence now, with almost 20 years of experience behind us, that they will regard those questions as at least on their long list as they go about deciding how to use their resources. I thought I'd put in a slide about cost effectiveness. It has over the years been one of the most controversial aspects of what NICE does, the fact that we might say no to a new treatment or shape a clinical guideline in a way based on a judgment of value for money, inevitably generates both concern and in some cases real anger and disappointment if it doesn't actually produce the outcome that any particular group is looking for. And it's a schematic that just describes the flexibility that we give to our advisory committees. It isn't black and white. It isn't, if it comes to this point in when we've actually done the economic analysis, if this is the number that's generated, then you have to do these things. There's an opportunity for a degree of flexibility between £20,000 and £30,000 per quality adjusted life year as different factors, the confidence in the calculations, the range of the incremental cost effectiveness thresholds that are generated by the economic analysis. Whether or not health-related quality of life has been captured sufficiently, and if not, is there something that the committee themselves need to decide as best they can based on the available evidence to take into account. And are there any other relevant non-health benefits? So, for example, the carer benefits that you might expect to be generated for treatments that are used for managing chronic conditions, where the contribution of carers is, in some cases, significantly greater than the contribution that the NHS makes in those treatments, can have, in effect, a knock-on effect for carers. And then for particular treatments, typically, I mean, they are almost exclusively cancer treatments that have the ability to extend life when we're right at the end of life, within a few months. We've exhausted all the existing treatments that are available. If there's something that has the benefit to extend life, or the ability to extend life at that point, then the advisory committees have the discretion to approve interventions at a higher cost per quality. Now, that's all good, you might think, certainly looking at it from the perspective of a patient that might benefit from that flexibility, or from the perspective of a company whose product might benefit. But it's more controversial if you look at it from a purely population perspective. If you think that the purpose of those, or the primary duty of those who've got the stewardship responsibility for resources in the NHS, is to apply them equitably, or is to maximise, more specifically to maximise the benefit from that money, then doing this, in effect, accepting interventions which are not cost effective by going above the threshold that you use, it's not the right thing to do. And NICE has its critics amongst the health economics community for doing this. And indeed, we're already criticised for starting at £20,000 per quality. The most recent empirical work that's been done on the appropriate threshold for the NHS suggests it's something closer to £12,000 per quality. Well, if we apply that to the interventions that we're looking at the prices, even the low prices that, in general, the NHS is able to get from life sciences companies, our chances of approving much would be very low. It's not a question that NICE can resolve. It's not our job formally to decide what the threshold is. We've been using this threshold. We extended the threshold range with the agreement and approval of the Department of Health. It's those who've got stewardship responsibilities for the system in the Department of Health and Social Care with their colleagues in NHS England who ultimately have the responsibility to decide what the appropriate threshold is. But this is what it is at the moment. This is what we apply. So just moving swiftly through a series of slides that talks a bit about how we look at technologies that have got an innovation or innovative label. There are lots of them, and the range of true innovation is wide. And importantly, the range of the impact, the incremental therapeutic benefit of that innovation where it exists is also quite wide. Something can be quite innovative, but not offer much in the way of incremental therapeutic benefit. So it's not the innovation that we should be buying, it's the value that that innovation brings that's so important. And in order to help us establish that, it's really important that life sciences companies do these things. They need to think about the entity that they're doing business with, what its ambitions and what its constraints are. The NHS at the moment, and I don't need to tell you this, is under enormous financial strain. I've been working in the NHS now since 1975, so I've seen a few cycles of boom and bust in the system, and this one is really very tight. And it's very important that life sciences companies understand that. And they can get into the detail of what the NHS is looking for, how to craft a really great value proposition by taking advantage of the opportunities, talking to us through our scientific advice program, for example, just as they do with the regulator, to help to better understand how to put together the proposal that they're going to ask us and the wider NHS to look at. But we've got some responsibilities too. The NHS generally, specifically NICE, we need to be clear about how we measure value. That's why it's so important to have the methods guide that I talked about earlier on. It's why it's important that we provide the opportunity for those pre-evaluation meetings, the scientific advice meetings, so that we can talk to companies, not about how to pass the exam and give them a glimpse of the questions they're going to get, but how to talk to them in general, about how we go about evaluating their products and how we do that in the context of the NHS as it is at the moment. We need to be flexible in the way that we go about evaluating products. Some of the things that we look at are relatively straightforward, others are much more complex, and we need to make sure that we can adapt how we go about our evaluations in order to make sure that we recognise those differences. And some of the changes that we're putting in place this year in the way we go about evaluating new health technologies will help to do that. And the same thing with the timeline. So if we've got something simple, let's try and do it quickly. We don't necessarily need to apply the heavy health economics to something that's pretty obvious in terms of its value proposition. Let's reserve that for the more complex value propositions that come forward. And as those complex value propositions are combining with novel technologies, the potential for the NHS to have to fork out substantial sums of money on the basis of a positive recommendation from NICE is growing. The example of the raft of hepatitis C treatments that have come in over the last few years demonstrates that the NHS needs to be able to have a dialogue with the companies that are introducing those products, not as a means of avoiding their introduction, and that certainly hasn't been the case with the hep C treatments. Most of them, for most of their indications, have been supported by NICE. But to sensibly manage their introduction into the NHS in circumstances where to try and do it in all one big bite has the potential to destabilise the budgeting that the NHS has to do for all the other things that we expect it to do for us. And where we do have that high net budget impact technologies, to make sure that we know about that as early as possible so that we can build into our evaluation an opportunity for NHS England as the main commissioner, typically for most of the things that we look at that have these characteristics, and the company to come together and say, well, is there a way, let's really test out our estimates of the resource impact. Have we got that right? Is there anything the company can do in order to support the NHS? Is there any reasonable patient stratification that would be acceptable to professional communities and to patient groups that might be explored in order to help to manage the introduction of these very expensive technologies? And it's really important that we don't separate out the idea of a commercial negotiation done between a company and NHS England from the evaluation that NICE does. Because if we do that, then we will seriously risk, I think, detaching the decisions that the NHS might make about the introduction of new technologies from the judgment about their value, the judgment about their incremental benefit. That's where we have to start in any discussions with companies and with the health system about making decisions about what technologies to introduce and how to do it. And along with those commercial agreements, we can put in place what are being described as managed access arrangements. So they have some of the characteristics I've just mentioned. They can be helpful in circumstances where there's uncertainty about the long-term value of a technology. So, for example, these managed access agreements with these sort of components are being used to draw funds from the new Cancer Drugs Fund, not the old Cancer Drugs Fund, when effectively there was an opportunity for companies to seek approval for a product that NICE hasn't supported. But the new Cancer Drugs Fund, which NICE is now responsible with NHS England for managing, is being used in a much more creative and positive way, I think, in order to help those technologies where there was a risk, or there is a risk, that a NICE advisory committee might say, it's too uncertain, we better not say yes. The committee can now say, it's uncertain, but there's real potential, we just need more data. Let's put together a proposal in conjunction with the company, very often with patient groups. That's particularly the case when we're looking at treatments for very rare conditions, so the enzyme deficiencies, for example, where there are tiny numbers of patients, but often very active family-based patient organisations. Bringing them into the discussion helps to bolster support for the ultimate recommendation and the adoption of the technology. So they're not necessary in every case, but where we are attempting to better manage the risk between the innovator who spent loads of money and time developing the product and needs to start getting a return, and the risk incurred by the health system that they might be investing something that simply doesn't, in the end, turn out to have the value that the innovator thinks it does. These managed access agreements can be very helpful. And although much of the way we craft our guidance is targeted at you, it's written very much with clinicians in mind. There is another important audience that we need to convince, those who you work with at a local level, who are managing resources in the very tight circumstances I mentioned a few minutes ago. They need to understand how the therapy, if we're supporting it, is going to change clinical practice. Are there any opportunities for savings locally, for changing the nature of how money is spent at a local level as a result of the new technology? And what way is that going to go? I mean, is it going to generate savings or is it going to increase costs? Are there things that need to be done beyond the acquisition of the technology in order to introduce it and to enable it to be used on a day-to-day basis? The real challenge, frequently, when we're looking at innovative new technologies is not so much in the work that NICE does, with all of its complexity, all the discussions we have to do with companies and NHS England. It's actually when we've got a decision, getting it adopted and used on a day-to-day basis, on the basis of the way the recommendations are formulated, is often very frustrating for everybody involved. So what are the key tests, just summarising now in the last few slides, for innovative technologies? I think there are 3, there are more, I'm sure, but in practice these are really important. Going back to my first point about the relationship between innovation and therapeutic value. It's the therapeutic value that we're buying, not the innovation. So the innovation has to demonstrate real incremental therapeutic benefit. Easy to say, it's not always easy to identify that absolutely and confidently at the point at which we're looking at something right at the beginning of its journey into clinical practice. But with the flexibilities I mentioned, we have got the ability to take some risk on the behalf of the health system to support those technologies where we're not absolutely certain. But there has to be plausible potential for something to bring real incremental therapeutic benefit for us to support it. Companies have to be realistic about the premium they're asking for new technologies. We know they've spent a lot of money. We know they need a return. There's nothing wrong with that at all. But that return has to be commensurate with value, and it has to be sensitive to the fiscal realities that the health system is working under. And then the third point is really the one about risks. It's fine to say, look, we're super confident about this. If you buy this one, the next one coming up that builds on this technology is going to be even better. You've got to invest. If you don't, we're not going to be able to put the money in. It's all entirely reasonable, but it all does come back to an appropriate balance of risks. Companies can't expect health systems to buy their products simply because they think they're innovative and they think that the next one or the one after that coming down the track is really going to be the blockbuster. We equally can't turn our face away from working with the industry in order to make sure that they're appropriately supported and rewarded for the risks that they take. There's a balance to be struck, and NICE is right at the heart of that process. So, going back to where I started, this is a complex world, and to do it well, what we've learned over the years is that you have to have a safe space to engage, to do all the things that I've been talking about, to enable everybody who's involved to get round and feel confident that they can say the things they need to say, and for those to be taken into account seriously. Maybe not going to make the difference in the final decision, but they need to be able to talk about their ambitions and their constraints. We need to be able to have the opportunity to explore the limitations and the uncertainties in the data. We need to talk about when to apply those flexibilities I mentioned earlier on. And critically, by bringing people together and allowing them to talk to each other, and by securing the mutual respect during that conversation that's necessary, we can build confidence in and support for the outcome. That's very definitely a critical part of the experience that we've had over the last 20 years. And finally, as if all this wasn't complicated enough, the world is getting even more complicated, and you know all these things at least as well as I do. The potential for new data sources to open up new ways of resolving at least some of the uncertainty that I've been mentioning that our advisory committee face through taking advantage of real-world data, particularly where we're updating existing pieces of guidance. If there is real-world data of sufficient quality that we can use confidently, then we need to do that and take advantage of it. And maybe big data too, at least for some of the things that we're looking at, where we can bring data sources together that typically aren't being used together, possibly particularly in the work that we do in public health and social care. Then again, we need to be in a position to understand the potential. Not to just say, as I hear people do, real world and big data is the future. Well, I'm sure they're part of the future, but we're not going to abandon the sort of studies that I was listening to towards the end of the presentation just before mine. They are going to continue to be a critical part of the bedrock of the evidence base that we need in order to make the recommendations that you'll have confidence in, which is so important. New digital platforms for accessing information, advice, and sharing data. I missed the digital approaches to interpreting data. Machine learning and artificial intelligence. Again, they roll off the tongue as if everybody knows what they mean. I certainly don't. I've got some understanding of it, and enough of an understanding to be reasonably confident that it's coming our way. And an organization like NICE, as a kind of information intermediary, needs to understand the potential and to take advantage of the potential of new ways of both gathering and interpreting data. The sort of work that we do must at least have the potential to be made more efficient and more rapid by using aspects of machine learning. And I'm pretty confident that that's going to happen. So we are already starting ourselves to make an investment in trying to understand the potential for these technologies for improving the efficiency of the work that we do. Because with that enormous back catalogue, unless we're really very smart, we're simply not going to be able to keep what we give to you up to date. And if we can't do that, you're not going to use it anymore. We need to be able to do that in a way that you're confident with. And new technologies potentially hold the opportunity for us to do that, at least to some extent as well. And then, of course, all the new technologies, the new science that's coming along, that's snipping away at our genes and producing some truly revolutionary opportunities for making enormous advances in medicine. We need to make sure that our evaluative frameworks are able to accommodate the data that those new technologies are bringing, as well as being able to work with the health system to be able to afford them. Because the potential for these things to cost huge sums of money for relatively small numbers of patients is very real. So we're going to have to evolve. We certainly hope we do. Without that, we simply can't maintain the credibility we've got, the support that I hope we have most of the time anyway from you, and with your support I hope we'll be able to do that. So again, thank you very much for the opportunity to speak.